How's it going, guys? We have a medium difficulty question for cardio, and we've got this ECG here, which some of you are going to complain. Okay, you say, Mike, it's too small, or Mike, I can't relax. Okay, so I don't know what to tell you. I made it the largest I could. The correct answer here is choice D for pericarditis. We've got diffuse ST segment elevations, and we have PR depressions. The autoimmune disease is what's causing the serous pericarditis. Lupus, rheumatoid arthritis, cocaine, viral infections, very high yield causes of serous pericarditis. Post-MI, you can get fibrinous pericarditis within hours to a few days. And then you can get a second type of fibrinous pericarditis 2 to 6 weeks later that's antibody mediated called Dressler. All right. So post-MI, you give aspirin for pericarditis classically, followed by colchicine. In this case, it's not MI, so you can use just a regular NSAID like indomethacin. You basically treat it the same as you would acute gout. Okay, so you give indomethacin, you give colchicine. Steroids are second line. So it's going to be central chest pain that's worse when you lean back, better when you lean forward. They can say the patient walks in bent over at the waist, okay, because they're obviously trying to lean forward. So let's just whip through some of the other answers here. Choice A, atheromatous plaque and calcification of the right main coronary. Well, that's going to be an inferior infarct if we had isolated ST elevations in 2,3 AVF. So the PDA, which supplies the diaphragmatic, the inferior surface of the heart for 2,3 AVF, the inferior leads, 80 to 85+% of people are right dominant, meaning the PDA comes off the right coronary. So USMLE can just have right coronary as the answer. If they say the patient is left dominant, the sequence they want is left main coronary goes to left circumflex, goes to PDA. Wrong fucking answer. Choice C, LAD infarct, wrong fucking answer. That's going to be ST elevations in the anterior leads. Holy shit. Okay, so V1 through V4-ish, isolated. So in MI, you're going to have ST elevations in 3 to 4 contiguous leads, whereas pericarditis is diffuse ST segment elevations with PR depressions. Wrong fucking answer. Choice C, convoluted answer choice for atrial fibrillation, wrong fucking answer. So you'd see irregular rhythm with absent P waves. So you don't have atrial depolarization the way you're supposed to, so the P waves aren't there. And then you have no defined pattern between the QRS complexes. So you look at the ECG and you say, there's no set distance between the QRSs. That's just atrial fibrillation. We could do a lengthy seminar on AF. I've made other clips on it. But you should know that you can get left atrial mural thrombi due to the stasis, the turbulence within the LA conduit. And that can launch off to the brain, cause stroke TIA, launch off to the eye, retinal artery occlusion, launch off to the mesenteric vessels, so mesenteric ischemia, launch off to one of the limbs, acute limb ischemia. Wrong fucking answer. Choice C, Wolff-Parkinson-White, wrong fucking answer. So bundle it can. It's just an accessory pathway. It can be anterograde or retrograde. And the only thing you got to know for Wolff-Parkinson-White is that you have the buzzy delta wave, right? So that's going to be a slurred upstroke of the QRS complex with a shortened PR interval. Wrong fucking answer. You know the deal. I'm 2 minute more content. I still screenshot. Appreciate your time. That's it.